Okay, so picture this. It's like 2 in the morning, you're absolutely exhausted, right? Just desperate for sleep,
Oh.
but you can't drift off. And it's because your nose, it feels like it's been filled with concrete.
We've all been there.
We've all been there. You're tossing, you're turning, maybe stacking up pillows to try and get some kind of leverage against gravity. A stuffy nose is a universal human experience.
Usually, yes. I mean, it's annoying, but it's temporary. A cold, maybe seasonal allergies, a sinus infection that clears up.
A nuisance, not a crisis.
Exactly.
But today, we are going deep on a case where a stuffy nose wasn't just a cold, it was this massive medical puzzle, and it involved a 32-year-old software engineer named Ravi. I'll tell you, by the time we get to the bottom of Ravi's case, you are never going to look at a sniffle the same way again.
It really is a fascinating case. It perfectly illustrates how a doctor has to think like a detective. You start with this very common complaint, I can't breathe, and you have to whittle down all the possibilities, from, the common cold to a dangerous tumor, all using just questions, physics, and a few simple tools.
So our mission today is to dissect this clinical case of bilateral ethmoidal polyposis. We're going to look at the patient history, the physical exam, which, spoiler alert, involves some surprisingly low-tech poking,
Very important poking.
and the eventual surgery. So let's meet our patient.
Right, so we have Ravi. He's 32, male living in Bangalore, and he works as a software engineer.
Now, normally that software engineer part might not seem important, but in this deep dive, everything matters. But first, the basics. Why do we care so much about his age and gender right off the bat?
Well, this is your first filter. In the world of ear, nose, and throat medicine, ENT demographics are huge clues. Think of it like a decision tree. If Ravi were an adolescent male, say 14 or 15, and he came in with a blocked nose and maybe some bleeding, my mind immediately goes to something called juvenile nasopharyngeal angiofibroma.
Which sounds intense.
It is. It's benign, but it's locally aggressive. A vascular tumor, which means it bleeds a lot. And it's very specific to young males.
But Ravi is 32.
Right, and if he were, say, 70 years old, I'd be much more worried about a malignancy, like a carcinoma. Cancers tend to show up later. Ravi, at 32, is in the middle, so we're thinking more along the lines of inflammatory conditions. Polyps, maybe?
Okay, so he's in the inflammatory zone. Let's look at the symptoms. He says the blockage started on his right side, then it moved to his left, and it's been getting worse for a year. But here's the detail that caught my attention. He says the obstruction gets significantly worse when he lies down flat.
That is a classic mechanical clue. It's one of those aha moments for understanding the physics of the nose.
Why does lying down change anything? I mean, if it's blocked, isn't it?
Not necessarily. There are actually two things happening here. First, plain old mechanics. If you have what's called a pedunculated mass,
It's a mass on a stalk.
exactly, like a grape on a vine, it's mobile. When you lie back, gravity pulls that mass backward into the choana.
And the choana is the back opening of the nose.
Right, the doorway to the throat. So the mass physically falls back and corks the airway like a ball valve. As soon as you sit up, gravity pulls it forward a bit, and you might get a tiny sliver of air.
That sounds incredibly frustrating.
Oh, it is. But there's also a physiological reason. When you lie flat, you get venous pooling in your head and neck.
Okay.
Gravity isn't pulling blood down to your feet as effectively. So the blood vessels in the nasal lining, the mucosa, they swell up slightly from that increased pressure. If your airway is already narrow, that little bit of extra swelling is enough to shut it down completely.
That makes so much sense. So it's a mix of a moving obstruction and blood flow. Now, Ravi also mentioned that dust makes it worse, which points to allergies. But then we get to the self-medication part. He's been using nasal drops
And this is a huge red flag in the patient history.
because everyone overuses them, right?
Pretty much. Ravi says the drops give him temporary relief, which tells us the tissue inside can shrink. It's vascular. But, and this is a big but, there is a condition called rhinitis medicamentosa.
That sounds like a spell from a fantasy novel.
It's less magical and more miserable, I promise. If you use those over-the-counter decongestant drops for more than, say, 5 to 7 days, your nose gets addicted to them.
Addicted to a nasal spray.
Chemically dependent. The nose starts to rely on the spray to keep the blood vessels tight. When you stop using it, you get this rebound congestion.
Yeah.
The vessels dilate massively, and the nose swells up even worse than before.
Wow.
So a doctor always has to ask, is this the original disease, or is it a side effect of the treatment?
Now we have to talk about the yuck factor, the discharge.
The clinical term is rhinorrhea, but yes, let's talk about the snot.
Ravi has watery discharge. It's not bloody, not smelly, and apparently this is good news.
It's very good news. In this detective game, the nature of the discharge is a massive branching point. Water usually points to allergy or inflammation.
But if it was bloody,
If Ravi had said it's blood-tinged, the whole mood in the exam room would change. Bloody discharge in an adult is a malignancy cancer until proven otherwise.
and what about foul smelling? The notes mention that specifically.
That's another fascinating rule of thumb. If a child comes in with a foul-smelling discharge from just one side of the nose,
A pee. It's a pee up the nose.
it's almost always a foreign body. A pea, a bead, you name it, it gets stuck and it starts to rot. But in an adult, a unilateral foul-smelling discharge implies tissue death, necrosis. So again, a high suspicion of malignancy or a severe fungal infection.
Okay, so Ravi's watery, clean discharge keeps us firmly in that inflammatory or allergic category.
Exactly. We've ruled out the bead up the nose and we're less worried about cancer for now.
Okay, I want to take a quick sidebar here because the source material had some absolutely wild medical trivia related to symptoms. We have to talk about merciful anosmia.
Ah, yes, atrophic rhinitis.
Anosmia is loss of smell, right?
Mm.
Ravi has a reduced sense of smell. But merciful anosmia sounds almost poetic.
It's poetic, but it's tragic. In atrophic rhinitis, the inside of the nose is essentially rotting. There's crusting, bacteria, and a terrible foul odor. It smells horrible to everyone around the patient. It's socially isolating.
But the patient doesn't know.
That's the mercy. The disease also destroys the patient's own olfactory nerves, so they're walking around with this terrible odor that drives people away, but they have absolutely no idea because they can't smell it themselves.
Wow,
It's a classic board exam question, but it's also a very real human insight into how diseases affect people's lives.
that is wild. And there was another one, the office headache.
Oh, this one is so relatable. It's actually frontal sinusitis. The frontal sinuses are the ones right above your eyebrows.
Got it.
So imagine they're filled with fluid from an infection. When you lie down all night, that fluid just pools and collects. You wake up, the pressure is building.
Right.
As you stand up and start your day, that fluid starts trying to drain. The pain peaks right around midday.
Right when you're at the office.
Exactly. And then as the day goes on, gravity does its work, the sinus drains, and the pain subsides by evening. People think you're just allergic to work, but it's actually physics.
Amazing. Okay, back to Ravi. The doctors have done the interview. Now they're going to look inside. They use a tool, a nasal speculum, and they see something.
They perform an anterior rhinoscopy, and what they see is classic. The description is bilateral, multiple, pale, glistening masses.
And the analogy they use is a bunch of grapes.
Yes, that visual is the hallmark of nasal polyps. They look just like peeled grapes hanging in the nasal cavity. Smooth, watery, pale.
So here's the part that blew my mind. The doctor sees this mass, and they don't just look at it. They take a probe, which is what basically a metal stick, and they poke it.
The probe test. And it's absolutely essential.
Why? I mean, why poke it?
Well, you have to answer a crucial question. Is this thing I'm looking at a polyp or is it a turbinate?
And a turbinate is a normal part of the nose.
Correct. We all have them. They're bony structures that humidify the air, but sometimes they get swollen and can look like masses.
So what's the difference when you poke them?
A huge difference. Turbinates have bone inside and are covered in sensitive tissue full of nerves. If you poke a turbinate, the patient flinches. It hurts.
And a polyp.
A polyp is just waterlogged, swollen lining. It has no nerve endings. So you can poke it, move it around, and the patient won't feel a thing. It's insensitive to touch.
Insensitivity is clue number 1. What else?
Mobility. A turbinate is a fixed bone on the wall. A polyp is on a stalk. You can move it, it swings. And the third thing is bleeding.
Right. We talked about bloody discharge. So
Well-
if you poke it and it bleeds.
If you touch a mass in the nose and it bleeds easily, you stop immediately. Polyps are avascular. They're just edema, fluid. They don't bleed on touch. If a mass bleeds, you have to suspect vascular tumors, malignancies, something like an inverted papilloma.
So for Ravi, they poke it doesn't hurt, it moves, and it doesn't bleed.
And that's your diagnosis right there in the chair. It's a polyp. It rules out the scariest stuff.
They also did something called Cottle's test. Pulled his cheek to the side.
Right, that just tests where the blockage is. Pulling the cheek opens the nasal valve at the front. If breathing gets better, the problem is right there.
But for Ravi, no improvement.
No improvement, which means the blockage is deep inside, past that valve. It confirms the mass is filling the whole cavity.
Okay, detective work done. The verdict is in. Bilateral ethmoidal polyposis, which is a fancy way of saying he has polyps growing from his ethmoid sinuses on both sides. But what is a polyp? I mean, is it a tumor? Is it alive?
That's a great question. No, it's not a tumor in the cancer sense.
Okay.
Think of it more like inflammation that's just gone wrong. It starts with this chronic irritation in the lining of the sinus. The lining gets swollen or edematous, it gets waterlogged.
Like a blister almost?
Sort of, yeah. Imagine the lining becomes so heavy with fluid that eventually gravity just starts to pull it down. It hangs like a teardrop, and over time it elongates into that grape-like structure.
So it's basically a bag of fluid. And because Ravi's are on both sides, that ports to something systemic.
Exactly. Bilateral usually means a systemic inflammatory response, which brings us to a really fascinating concept called Samter's triad.
Right, the source material highlighted this as a major connect-the-dots moment for doctors.
It's vital. Whenever a doctor sees ethmoidal polyps, they have to ask about two other things: asthma and aspirin sensitivity.
Why? What's the connection?
It's a condition called aspirin-exacerbated respiratory disease, or Samter's triad. It's three things: the polyps, bronchial asthma, and an intolerance to NSAIDs like aspirin. It's a specific type of inflammatory disorder.
And if a doctor misses that connection?
It can be dangerous. Imagine you do surgery to remove the polyps. Afterwards, Ravi's in pain, so you give him some ibuprofen. If he has Samter's triad, that could trigger a massive life-threatening asthma attack.
Wow, the nose is just the tip of the iceberg.
Always. The nose and the lungs are one united airway. You can't treat one without thinking about the other.
So let's quickly cover what Ravi didn't have, the antrachoanal polyp.
That's the solitary polyp. It comes from the cheek sinus, and it's usually just one single large mass. Ravi had a bunch of grapes on both sides, so that was out.
And the other one that sounds terrifying, rhinosporidiosis.
That's a disease from a parasite. It presents as a strawberry-like mass.
We're using a lot of fruit analogies today. Grapes,
As if
strawberries.
Davidson loves food analogies. But this one really does look like a strawberry. It's red, granular, and it bleeds very easily. It's also studded with these little white dots.
And you get this from bathing in ponds with cattle.
Pretty much, it's an agricultural exposure.
Okay, Ravi is a software engineer in Bangalore. Probably not bathing in ponds with cattle.
Right. Context matters.
So we know what he has. Now, how do we fix it? My first thought is surgery, but that's not step one.
Not so fast. With polyps, because they're inflammatory, you always try medical polypectomy first.
Meaning drugs.
Exactly. Steroids, specifically. You use oral steroids and nasal steroid sprays to try and shrink that edema. The polyp is waterlogged, so if you can reduce the inflammation, the water leaves and the polyp shrinks.
But in Ravi's case, that didn't work.
The polyps were just too big, grade 3 or 4, filling the whole nasal cavity. If medical therapy fails, you have to move to surgery.
And the surgery is SESS.
Functional endoscopic sinus surgery.
But before they operate, they need a map. The source mentioned the gold standard investigation.
The CT scan. Specifically the coronal view, which is like looking at the patient straight in the face. It lets the surgeon see the relationships between the sinuses, the eyes, and the brain.
And on the scan, polyps look like a gray fog.
A homogeneous opacity, yes.
Yeah.
A uniform gray fog filling the normally black air spaces.
Okay, so let's talk SESS. It sounds high-tech.
It is. It's minimally invasive. The surgeon goes in through the nostrils with an endoscope, a camera, and tiny instruments. The goal isn't just to rip out the polyps, it's to restore drainage.
Like unclogging a pipe.
Exactly. It's functional because we want to restore the sinus function. They remove the polyps, but they also open up the natural drainage pathways by removing small bits of bone and clearing out the honeycomb of ethmoid air cells.
That sounds incredibly delicate.
It is. You have to remember where you're operating. The ethmoid sinuses are separated from the eye socket by a bone as thin as paper.
Paper thin.
The lamina papyracea, yes. If a surgeon slips just a few millimeters to the side, they can breach that bone, damage the eye muscles, or even the optic nerve that could cause blindness.
That is terrifying. And what about going up?
Right above the ethmoids is the skull base, the brain. If you go too high, you can breach it and cause a CSF leak, brain fluid leaking out of the nose.
Which can lead to meningitis.
Right. So the surgeon needs that CT scan map. They need to know exactly where those boundaries are. But in expert hands, SESS is a fantastic surgery. The patient wakes up breathing freely for the first time in years.
So, to recap. We started with Ravi, who couldn't breathe. We used his age and that key symptom, worse when lying down, to suspect a mechanical blockage.
We used the probe tests in sensitive and mobile to confirm it was benign polyps and not some scary tumor.
We learned polyps are basically waterlogged grapes of tissue and connected them to asthma through Samter's triad.
And finally, we looked at the high-stakes plumbing of FES surgery, navigating millimeters from the brain and eyes to clear the blockage.
It's incredible. We usually just ignore our nose until it stops working.
We do. But the nose is the guardian of the airway. It filters, it humidifies, it smells. Ravi's case is a great reminder that a persistent symptom, especially one with quirks, is your body trying to tell you something specific.
So next time you have a cold, be grateful. It's just a cold.
Yeah.
And if you ever lose your sense of smell, but your friends say you smell terrible.
Go see an ENT immediately. It might be merciful anosmia. And definitely don't use those nasal drops for more than a week.
Words to live by. Thanks for listening to this deep dive. Keep breathing easy, everyone.
Take care.